Hello, I am Oriana Lowe, a pediatric dentist. Today we will be having a lesson on orthodontics for the child patient. Objectives of this course is to list some of the more common orthodontic problems seen in the child patient, to understand different phases of orthodontic treatment, to recognize the more common appliances used for the child, and to describe the etiology and treatment options for occlusion and space maintenance. What is orthodontics? Orthodontics is that area of dentistry that prevents, diagnoses, and treats dental and facial irregularities. One can use fixed or removable appliances to affect the changes in moving teeth, retrain muscles, and affect the growth of the jaw bones. Orthodontics is the prevention of malocclusion through successful orthodontic intervention. Early interception is based on diagnoses and prevention in young age groups, therefore reducing the severity of malocclusion noted in later life. Interceptive orthodontics is important for patients who have severe malocclusion. Many times, this treatment is done in two phases. Phase one is the phase that young patients can really benefit from. It takes advantage of the growth of the jaw bones and development of the teeth. Appliances used for phase one treatment include habit appliances, arch development appliances, lingual arch and space regaining appliances that correct crossbites and are semi-functional. Here are some pictures of cases where orthodontic is highly recommended. First, you see a crossbite and crowding of the front teeth. The middle picture on the top, you have a crossbite of the back teeth. The next one on the right, you have lower anterior crowding, and then followed by an open bite, and then protrusion of the maxilla, a deep bite. The lower left is an underbite or anterior crossbite or full crossbite, if you want to call it that, and spacing in the arches, and then a picture of a patient sucking on their fingers, which oral habits has a great effect on developing malocclusion. Treatment of crossbites is one of the less challenging procedures that orthodontics can perform. Treatment is usually done in the early mixed dentition stage. A single tooth crossbite can be corrected with braces or a retainer to move it into correction. Many times, just biting on a popsicle stick can help affect correcting a single tooth crossbite if it's an anterior tooth. One tooth crossbites can be treated simply without orthodontic appliances, and using a popsicle stick is an example of how that can be done. So let's talk a little bit about phase one orthodontic treatment. This is also called interceptive treatment. It is recommended to patients between the ages of 7 and 10 after eruption of the permanent first molars and incisor teeth. For children who have moderate to severe bite problems, such as a crossbite, an underbite, or an open bite, and it may be recommended for severely malaligned or crowded teeth. Teeth are still developing and the jaw is still growing. This is characteristic of a good time for interceptive orthodontics. Interceptive orthodontics preserves and maintains normal relationships in the developing occlusion. It is treatment with a limited objective, not necessarily involving the entire dentition. Interceptive ortho is an extension of preventive orthodontics that may include localized tooth movement. Such treatment may occur in the primary dentition and may include procedures such as redirecting ectopically erupting teeth. Procedures that we use in interceptive orthodontics include serial extraction, correction of developing crossbites, control of abnormal oral habits, regaining space, interception of skeletal malrelationships, and removal of soft tissue or bony barriers to enable eruption of teeth, such as what we see for ectopic eruption purposes. Interceptive orthodontics can be provided using various appliances which are fixed, removable, and you can extract teeth for this purpose. So, what is phase 2 orthodontic treatment? Most patients after phase 1 treatment will require phase 2, but sometimes, on occasion, further treatment is not necessary after phase 1 treatment. After phase 1 treatment, a shorter and less complex phase 2 treatment would be rendered. Phase 2, the purpose is to align all the teeth into a perfect position or to detail the bite, with the bulk of the correction being completed in the first phase. And phase 2 is usually done in the permanent dentition. So what is comprehensive orthodontic treatment? Comprehensive orthodontic treatment is conventional braces, sometimes with another ortho appliance at the same time. Usually this can take place between the ages of 11 or 12, when most of the permanent teeth have erupted. It takes up anywhere from 12 to 30 months. Patients do not have severe bite problems or crowding that require early intervention. And these patients who do have severe bite problems, like a moderate to severe overbite, they are better suited for treatment when they are at an earlier age. So these type of patients with the severe bites are recommended to have phase 1 treatment before undergoing phase 2 treatment. Cross bites. There is a range of causative factors, including genetics, environmental factors, and habits that will cause cross bites. Frequently, cross bites result from a transverse maxillary skeletal deficiency that may have an underlying congenital effect, such as trauma or iatrogenic basis. Spontaneous corrections sometimes occur, and diagnosis involves situation or evaluation of the face and the transverse relationship on study models and x-rays or radiographic diagnoses. Reasons to correct crossbite: to prevent premature wear of the teeth, to prevent gum disease including bone loss, asymmetry development of the jaws, dysfunctional chewing patterns, and causes relating to jaw dysfunction, which is TMJ. Many times a crossbite can cause TMJ problems. Treatment of crossbites are usually done in the early mixed dentition, if possible. Single tooth movement, braces or retainer may be used. Multiple teeth may require a palatal expander, and a unilateral posterior crossbite. Many times we use a rapid palatal expander with reverse crossbite elastics on the non-crossbite side in conjunction with another appliance, such as a lower lingual holding arch. Anterior single tooth crossbites, a tongue blade or popsicle stick therapy can be used, although this will success of this type of treatment is dependent solely on the parent and the patients using this bite. The parents getting after the child for using it or insisting that they use the popsicle stick therapy. Acrylic bite planes can be used as well as something fabricated by the dentist, and a finger spring retainer that's removable or fixed. Okay, here is an example of the tongue blade popsicle stick therapy. You see the child in the middle picture biting on the stick, but it has to be done in 15 to 30-minute intervals for several hours a day, and it depends highly on the patient cooperation. Correction is unlikely if the tooth is fully erupted. So you have more success if the tooth is still erupting. So that's why starting early, let's say at the age of around 7 to 9 or 10, is helpful before the anterior teeth fully erupt. So here are some pictures of appliances for anterior crossbite. You have a fixed appliance NB with a spring behind the one anterior tooth. Then you have a removable appliance with a spring in the next photo. And again, on D, it shows you the success of the fixed appliance from picture B. On the lower picture on the model, you have a bite plane. So that can be placed on the lower arch. So every time the teeth come together in occlusion, the upper teeth bite against that acrylic plane, pushing the tooth that is a crossbite forward. So let's talk a minute about palatal or maxillary expansion. These expanders are used to widen the circumference of the palate and the perimeter of the dental arch. It is indicated before the maxillary sutures have completely closed. It corrects the crossbite due to a narrow palate. It eliminates or reduces overcrowding, and it improves ability to breathe for many patients with a narrow or deep upper jaw. Here are some examples of palatal expanders. You have a Hyrax, a bonded Hyrax appointment, and the Haas. The Hyrax is a fixed appliance that's cemented in the mouth. You have a bonded Hyrax that has an occlusal plane that opens the bite of the patient, and this will many times help expand the jawbone faster. And then the Haas appliance is an acrylic appliance that's put on the front, and you can see that all three of these expanders have a key meaning an appliance in the palate area that can be opened. You see an arrow that's in the jack screw area, and the appliance is moved with a key that moves in the direction where the key is shown, or the arrows are shown. So a little word about palatal or maxillary expansion. A quad helix, which is the appliance shown in the photo below, is an appliance for the upper teeth that is cemented in the upper arch. It is attached to the molars by two bands and helix springs that widen the upper arch of the mouth to make room for crowded teeth. An open bite is an inadequate vertical overlap of the front teeth. It may be in the anterior or posterior, but most commonly in the anterior. Open bites are due to super-eruption of adjacent teeth or infra-eruption of involved teeth. It may be caused by oral habits such as a tongue thrust, digit sucking, or deviant growth patterns, and it could be genetic. Timing of treatment is critical to the overall success of this type of therapy. A little bit about habits. Thumb sucking or finger sucking is the most common oral habit in children. The effects of these habits is influenced by the age of the child, the direction of the force applied, and other skeletal and soft tissue factors. Here we have pictures of children sucking their thumbs. So they're all at different timing. You know, here's a little infant, here's a toddler, and another toddler. Here's a toddler asleep with the thumb in his mouth. Here's one that has a pacifier. So the longer the pacifier and the thumbs are retained in the mouth, the more deleterious effects of open bite and malocclusion. So let's speak a little on vertical relationship of dental arches. The vertical relationship of the arches is described by the presence of a closed bite, open bite, anteriorly or posteriorly. There are different types of malocclusions. Overjet. An overjet is where your top teeth extend past your bottom teeth horizontally, not to be confused with an overbite. You have an overbite that covers, it's the relationship between the upper teeth to the lower teeth and how much coverage these teeth have to the lower teeth. A crossbite is very prevalent. Anterior crossbite or an underbite it can be called a class 3 malocclusion as well, depending on the growth of the jawbone. Spacing, a diastema in the front teeth is also considered a type of spacing. Impacted teeth and missing teeth will cause malocclusion. Malocclusion occurs in 3 planes: anterior, posterior, vertical, and transverse. Class 1 molar relationships. In this type of relationship, the occlusion of the maxillary and mandibular molars is such that the mesobuccal cusp of the maxillary molars occludes in the mesobuccal groove of the mandibular molar. That's the normal relationship that we all would like to see. People with this relationship exhibit a normal dental bone frame. Crowding of the lower incisors is common and tends to become more severe with age. Crowding may be due to mesodrifting of the buccal segments and uprighting of the lower incisors that occur in the late teens. What is malocclusion? Many malocclusions are inherited. Malocclusion is a normal genetic variation in the size of the teeth, muscles, and bones. It is usually a problem if it bothers the patient. It's the variation in siblings that gives them a distinct look and prevents any two people from looking alike. Here you have some graphics of bite problems. A healthy bite, an overly crowded bite, an overbite that's very deep, and an underbite where the lower teeth juts out further than the upper teeth. Types of malocclusion, you have a class 3 bite is the first one you see. A class 2 is one where the upper tooth protrudes out, and a class 1 where you have a normal relationship. So here we go again. Malocclusion, the teeth do not come together. And normal occlusion, you have the teeth coming together where the mesobuccal cusp of the upper maxilla is in the mesobuccal groove of the lower molar. And again, examples of occlusion. This is a picture of class 2 malocclusion where the teeth do not meet correctly. And you see that the profile of the child, they have a protrusive upper jaw. An open bite, here you see that the teeth do not come together in the front. You kind of see the tongue trying to protrude through the upper and lower segments. Severe crowding, you see that there's a deep overbite, there's crowding where the upper canine cannot come into the occlusal plane. So let's talk a little bit about malocclusion again. Which of the following malocclusion describes a child in the primary dentition who presents with a classic skeletal and dental pattern with a retruded maxilla, a prognathic mandible, and a concave profile with retroclined lower incisors? What would you say is the answer? A retruded maxilla, prognathic mandible, concave profile, and a retroclined lower incisors. If you answered class 3, that's correct. Reasons to correct an open bite: the premature loss and wear of the back teeth, dysfunctional chewing patterns, and TMJ dysfunction. So these are reasons why an open bite should be corrected. Correction of the open bite can enhance the growth modification of the jaws, extrusion of the front teeth, surgical correction of the jaws, breaking oral habits such as digit sucking will many times facilitate the correction of an open bite and make the result more stable. In this instance, the success for stopping the digit habit is critical. Many times, if we are successful in helping to stop the digit habit, we will see not the collapse, but the formation of jaws to return to more of a normal state. A deep bite or overbite, which is a measure of the vertical overlap of the upper and lower front teeth. It may be caused by a disproportionate eruption of the front teeth, overdevelopment of the bone that supports the teeth, and is often seen in Class 2 Division 1 malocclusion, which is represented by an excessive overjet, which causes mandibular incisors to super erupt until they contact the palate. Many times it is seen in Class 2 Division 2 malocclusions as well. This is where infra-eruption of the posterior teeth or super eruption of the maxillary and anterior teeth is noted. Reasons to correct overbite. To correct the improper functioning of the front teeth and prevent lower front teeth biting into the gum tissue of the palate, leading to periodontal problems and a sore palate. You also will correct the unusual wear of the lower front teeth, which is seen in many times when there is excessive overbite. Correction of the overbite can be through orthodontic leveling of the front and or back teeth. Overbite due to skeletal Class 2 relationships can be corrected with orthodontic appliance such as an Herbst appliance or Forceps. I will now mention a bit about functional appliances. Functional appliances can be divided into fixed and removable appliances. Fixed appliances have to be bonded to the teeth by an orthodontist or someone trained to do orthodontic movement. Fixed appliances are able to produce a very accurate movement in the teeth. Removable functional appliances does not need to be bonded to the teeth and can be removed by the patient. A removable appliance is usually used by patients who have a high degree of compliance with their orthodontic treatment. Both fixed and removable functional appliances can be used to correct a malocclusion in 3 planes: anterior, posterior, vertical, and transverse. Many times, removable functional appliances are used by child movie stars. Many times, a child will come to the office and they may have bit rows on television or they're making a movie. Their teeth are maloccluded where they may have protrusion or an underbite. So the orthodontist will give them a removable functional appliance that they can take in and out of the teeth when they're not on screen. Functional appliances include activators, Prozacs, Bionators, and Francos. Their use and success depends on patient compliance. Here is an example of a Herbst appliance which corrects Class 2 malocclusions. A Herbst appliance enhances the forward growth of the jaw while applying backward pressure to the upper jaw. Usual age for success in use of this appliance is between 11 and 12 years of age, and it should be worn for 6 to 9 months. It is used to redirect and harness the natural facial growth during puberty. It prevents the lower jaw from moving backward through opening and closing movements, and the device is attached to the back molars on the upper and lower jaws with bands that are cemented in place, as you see here in the photo. A Forceps appliance is another type of the Class 2 appliance. It helps the patients that may not remember to wear the appliances. Possibly it's to help prevent the need for expensive jaw surgery. We used to do a lot of these cases, but we don't see them as often in our office. The appliance is made to align the teeth and reduce the overbite to promote the proper jaw growth in patients. It is used mostly in adolescents to coincide with jaw growth, and it is usually used between 6 and 9 months, depending on the severity. For protrusion and overjet, what is this? It is a forward positioning of the teeth relative to their bony base. It may occur in the maxilla, mandible, or both. Reasons to correct overjet is to prevent proper functioning of the front teeth. It is, excuse me, that was not written correctly. It is to prevent proper malfunctioning of the front teeth, and it can lead to premature wear of the teeth. So this is why we went to correct overjet. Underbite is a situation where the lower teeth are biting in front of the upper teeth, usually caused by undergrowth of the upper jaw, overgrowth of the lower jaw, or a combination of both. It's also what we consider a class 3 relationship. It can be caused by tipped back upper incisors, flared lower incisors, missing upper teeth, or a combination of all. This treatment may require 2 phases: comprehensive orthodontics, extraction, and surgery, depending on the cause and severity. Appliances include braces and elastics and reverse pull headgear. Correction of underbite. We want to correct early because this is where we get more success. It may be related to jaw joint dysfunction or cause some TMJ problems if it is not corrected. The correction of the underbite includes modifying the growth of the jaws, extraction of teeth, palatal expansion, and surgical movement of the jaws. These are different ways to correct underbite. Impacted teeth. An impacted tooth is one that has failed to erupt normally into the mouth and remains partially or totally covered by the gums or bone. This may be caused by an improper position of the developing tooth bud, premature loss of primary teeth, and crowding. Third molars are the most commonly impacted teeth. Canines and premolars are also commonly impacted. So coil springs used to regain space. So how many of you have used separating springs? Well, separating springs is this little coil spring that is placed between the teeth to separate or give space between teeth that are quite crowded. The reasons that you may want to treat teeth that are impacted is because they cause damage to the root surface of adjacent teeth, leave unwanted spaces. It leads to improper functioning of the teeth and causes asymmetry alignment of the teeth. Ectopically erupting canines. Etiologic factors are genetic, local environmental, systemic environmental, such as endocrine deficiencies. It occurs 2 times as common in females, and it is the second most commonly impacted tooth in the jaws. And again, the first most commonly impacted tooth is the third molars or the wisdom teeth. Canines usually erupt between 11 and 12 years of age. Treatment of ectopically erupting canines should be monitored before 10 years of age, and extracting primary canines if it appears the permanent canines will be impacted. Surgically exposing and bonding can prevent formation of cysts, periodontal defects, and resorption of the adjacent teeth. Space maintenance. What do space maintainers do? It maintains the mesodistal dimension of the space when a primary tooth is lost prematurely. It's used when a permanent tooth is missing. It may be fixed or removable. It helps to maintain individual functional movement of the teeth, and it should not be interfered with vertical eruption of adjacent teeth. Space maintainers should be removed when the permanent tooth begins to erupt. So here we have some pictures of anterior space maintainers. Anterior space loss does not result in space loss if the primary cuspids are erupted. It may interfere with speech if teeth are lost before speech development is complete. And the most valid reason to replace anterior teeth is for aesthetics, and lack of teeth may harm a patient's self-image. Posterior space maintenance includes, is used for premature loss of posterior primary teeth, resulting in meso-tilting of the tooth distal to the extracted space due to the meso-direction of the eruption of the first permanent tooth. So you see here two little photographs. The first primary molar has been removed, and nothing has been placed in its place to restrain the permanent molar from moving, the second primary molar from moving into that space. So what you have here is you've got mesomigration of number B, as you see in that photo, causing some space loss. Mandibular space maintainers, and what are these and what are some examples? We have a distal shoe, which is used when the second primary molar requires extraction and the first permanent molar has not erupted. A lingual arch is used when there is bilateral loss of the mandibular primary molars after eruption of the permanent incisors, and unilateral loss of one or more teeth in the mandibular arch. Ectopic eruptions may occur when the permanent molar has an altered path of eruption. The permanent molar can erupt in a detrimental position under the distal of the second primary molar. Most of these cases self-correct by age 7. By ages 7 to 8, they should be considered irreversibly locked. If these teeth don't correct by then you need to go in with some type of intervention. Ectopic eruptions of the mandibular first permanent molars, the incidence is 0.2%. It occurs 20 times less frequent than the maxillary first molars. And ectopic eruption is due to larger than normal teeth and inadequate arch length. And again, this is more commonly seen in the mandibular first molars. Ectopic eruptions include treatment variables to consider when preparing to treat ectopic molars, including extent of blockage, degree of E-resorption, and arch length. E-resorption is referring to the second primary molar and how much they resorb. What I want to do is to go back to this slide. I think I stated that the ectopic eruptions of the mandibular first molars, the incidence is 0.2. And there are more causes or ectopic eruptions on the maxillary first molars than there are the mandibular first molars due to the larger teeth and inadequate arch length, but it is more prevalent in the maxillary first molars than in the first permanent. Leeway space is the amount of space occupied by the primary canines and first and second primary molars that exceeds the space occupied by the canine and premolar of the permanent dentition. It usually averages about 1.7 millimeters on each side of the dental arch. And it is this leeway space that helps us with the crowding that may be prevalent in the dentition. Leeway space is that extra space gained upon the exfoliation of the deciduous canines and molars. These deciduous teeth occupy this space, which is a wider distance than the permanent replacements. Space regaining appliances include elastic separators, which is the first choice. brass wire appliances, Halterman appliances, pictured here, which is a button and chain, Humphrey appliances, which is an S-shaped wire that's used with an open coil on the lower picture, and disking of the lower anterior teeth, primary canines for minor space discrepancy in the lower anteriors. Humphrey appliance is used for regaining space and uprighting molars. So here is a case study where patient JP presented at 8 years of age. His mandibular first permanent had erupted. However, his maxillary first permanent teeth failed to erupt. Upon radiographic exam, we saw that number 3 and 14 was erupting in an ectopic position. A radiograph of 14 at initial diagnosis is shown, and treatment involved placing an elastic orthodontic separator, as you see here in this photo. So in itself, just placing the elastic separator uprighted the permanent molar. And here we go again. You see that 5 months has elapsed, and we still have success with that molar being uprighted, and resorption of the distal portion of the second molar has stopped. Oral habits include bruxism, abnormal tongue thrust, digit sucking, use of a pacifier. Habit-breaking appliances can be used to stop these habits. Bruxism is a medical term for the grinding of teeth or the clenching of jaws. 2 out of 3 of the children will grind or clench. Most will grow out of it. Bruxism often happens during sleep phases when the kids are under stress. There usually is no treatment for bruxism. A vinyl bite guard worn at night can be done, but we generally wait until the child is older, like 7 years old or more. Or we can do occlusal equilibration. Habit-breaking appliances include a palatal crib, or a Kentucky bluegrass appliance, or a hay rack. And these are pictures of these different appliances. A hay rack looks like a hay rack that goes in the mouth and it's cemented. When the child tries to suck their thumb, the thumb presses against the rack. Palatal crib works the same way, and a bluegrass is something that has a little knob that spins when they try to put the thumb in. Invisalign, a bit about Invisalign, are clear aligners that are used as an alternative to metal braces for adults and teens. They're an invisible way to treat malocclusion. So it's not for everyone. It's only for everyone that is an alternative to fixed appliances. And it has become popular for those kids that have special needs, because special needs kids can't sit in the chair for any length of time. So Invisalign has been a good option for them. And again, primary goals of treatment is to treat underbite, overbite, crossbite, spacing of teeth, open bite, and crooked teeth. And that's it. Clinical procedures to preserve space and guide eruption are reasons why early orthodontic treatment may be undertaken. To preserve arch integrity, stabilize molar and anterior tooth positions, and simple appliance therapy over a short interval to prevent prolonged treatment of permanent dentition is called phase 1 treatment. Indications include cross-bite, anterior open bite, protrusion, class 2 and class 3 malocclusions, and class 1 malocclusion for crowding. And that's it. Any questions, you can send me an email. Thank you very much, and it has been nice speaking to you today.